be able to follow the presentation of today. Please, are we done with the slide or the great? So that's what we had as information. Now we'll start with the modeler. Today we'll have Roland Christel Nunameto who will be presenting himself to you people. So let us give the floor to Roland. Please, Roland, you have the floor.
Hello. I hope you can hear me.
Hello. Yes, we are getting.
All right. So good afternoon, everyone. Depending on where you are getting me from, maybe good evening. I am Roland, and yes, so I'm Roland. I'm from Benin, and how best can I define myself? All right, so I'll simply put, I would say I am passionate about data and specifically about how to use data to improve our day-to-day life. And just to give you a little bit of story, so it all started during my undergrad studies, actually, where let me say, I fell in love with statistics. Then I decided to pursue further studies in biostatistics. And actually, during that study, I learned how to apply statistics to the life sciences. As I was finishing my degree, then COVID-19 emerged. Then I got an opportunity to actually use data to support decision making and then impacting people's life. So at the end of that, I realized how powerful this can be. Then I later shifted from COVID-19 to malaria. But let me tell you that the passion is still the same and the goal remains unchanged. I mean, it's use data to support decision making. And this has even become more critical as we're now facing a huge funding cuts, especially when it comes to malaria funding. So basically, in a nutshell, I'll say that I am a PhD student, and my work focuses on using different analytical tools on existing data to support decision making, with the ultimate goal to control malaria in my country, Benin, where unfortunately a lot of children are still dying from malaria. So basically, that's me, and I am happy to connect. I am happy to collaborate. Yeah, thank you very much. Thank you, Ahmed, for giving me this platform, this opportunity to showcase myself. Thank you.
Yes, thank you, Roland, for providing all the information about yourself. We are very happy to see that there are many people who are really doing well in modeling and supporting the National Malaria Control Program in the fight against the disease. It's very important that at different points where we are across the continent, we will really support the fight against the disease, which is really causing a lot of problem across the continent. So now we are going to continue with our next person will be a seminar which will be given by Ferguson Juvo. Ferguson Juvo is a public health professional and malaria data specialist with over 10 years of experience in malaria control, health information system, and infectious disease research in Ghana. He serves as an associate analyst and data manager with the Ghana National Malaria Elimination Program, where he works within the research, surveillance, monitoring, and evaluation unit to strengthen routine health information system, improve data quality, and support evidence-based decision-making for malaria control and elimination. So now we'll give the floor to Ferguson to really present to us his work. Thank you. Ferguson, the floor is yours.
All right. Thank you very much for the introduction. I think I have 30 minutes to do my presentation, and
Yes.
I think the topic of which I'm presenting on is from data to decisions, Ghana's national subnational tailoring approach for malaria interventions. So, all right. So the presentation will take this format, explain what subnational tailoring is, then the SNT context and background in Ghana, then the 10-step processes for the SNT processes, then the data architecture and then data quality pipelines, then how we estimated incidents, then the stratification risk mapping, intervention tailoring, then prioritization framework, then lastly, the stakeholders and key lessons learned in this year's SNNT. I must mention that this is a work in progress, and it's a collaboration with a lot of partners, of which they will be duly acknowledged at the end of my presentation. Okay, so what do we mean when we say subnational tailoring? Subnational tailoring, simply put, or in a layman's language, is just, moving away from the one national strategy fits all approach to using local level data at the subnational level or the district level to actually ask, what does this district or the next district need in terms of intervention to make sure that malaria prevalence and incidence is reduced to the barest minimum, or malaria is eliminated at the right time within the resource constraints or the resource available. So, in brief, that is how I define subnational tailoring. So there are three key areas to look out for. One is the local data. So we look out for subnational surveillance data, program data, or the program intervention data at district and then the facility levels. Then the second one is the context factors, which include seasonality, urbanization, entomology, and then the population dynamics across the various sub-levels of any country. Then the last one is the optimal allocation, which ensures that we have the right intervention mix, reaching the right people within budget constraints. Now, so for Ghana, we have 16 administrative regions and 261 districts. And in this year's subnational tailoring, the unit of analysis was at the district level. So it means we are doing analysis for all intervention based on the district, the 261 districts. Now, this is the third SNT exercise that Ghana is doing. We did the first one in 2019, the second one in 2022, and then there's the third one we are currently doing. And the purpose of this whole exercise is just so we are grounded, we have enough grounds for our next strategic plan with local evidence and then data-driven intervention mixes for the national strategic plan. Then secondly, it's also to inform Ghana's Global Fund Cycle 8 funding application with evidence-based prioritization. And then thirdly, to review and update the eligibility criteria for some interventions across different districts. For instance, IRS or indoor residual spraying, SMC, which is seasonal malaria chemo prevention, malaria vaccine implementation, and the new interventions that the program is bringing in place, such as mass drug administration, IPTSA, which is intermittent preventive treatment in school children, then PDMC, which is post-discharge malaria chemo prevention. So these are novel interventions that the program wants to bring in place. So to appropriately determine where these interventions are needed, we need a good subnational tailoring approach. Then lastly, to build evidence base for smart deprioritization decisions when funding is constrained. So these are the purposes for the subnational tailoring for 2025-2026. Okay, so for the steps or the processes for the subnational tailoring, there are 10-point steps which all countries go through, and same for Ghana. So we did the planning and preparedness, which included the team setup, the terms of reference for the teams, and then the resources each need. The second point is on data collection and management, where we look at for which data we need to answer which questions in specific sub-levels. So we talk of the National Malaria Data Repository, the DHIS2, which houses the routine surveillance data and other data for Ghana Health Service, then surveys, then other partner data. Then thirdly, we're looking at situation analysis, which includes the midterm review. Then we also do the stratification, the fourth step, where we look out for the prevalence, the incidence, and the burden mapping, which intervention goes where. Then fifth is the intervention tailoring. This is where we look at whether districts are eligible to enjoy some intervention supports and also prioritize some intervention targeting. Then the sixth point is the impact forecasting, where we do mathematical modeling. And this year specifically, I think the mathematical modeling is the specific area that were not done in previous SNTs, but this year includes the mathematical modeling, where we forecast impact of the interventions. Then the seventh point is the strategic scenario selection, where we align the NSP, and then budget optimization. In the resource constraint prioritization, we do budget optimization. The ninth one is the service delivery, and then last one, monitoring and evaluation. Now, this presentation is mostly dwelled on the point 2 and then point 4, which is data collection and management, and then stratification. And let me reiterate that this is a work in progress, and so I'll be more generalized on the presentation. Now, for data architecture, the SNT data for this year fell on 3 pillars. The first pillar is the routine health data. That is where we got our first source of data. The next source is the intervention data. And lastly, the transmission determinant. So with the routine health data, we're talking of the HMIS data, which we got the OPD cases, the testing, the confirmed malaria cases, and all the routine health malaria data. And this data was age disaggregated by facility level from 2015 to 2025. So about 11 years time point of data that were used in this year's SNNT by districts. It means that that's a lot of data for 261 districts for 11 years by age and then by facility. And then all cohorts under 5 OPD with severe malaria and then malaria mortality data were all analyzed at these levels. The facility level by age and then by districts. So 10 age groups with monthly data and then 200 districts constituted the routine health data. Then for the intervention data, we talk of specific interventions that are implemented in Ghana by various districts. So we have the ITN distribution through the routine and then the EPI and then also the mass campaign, which we got data as far back as the start of implementation of these interventions. Then we also have IRS coverage by district and by rounds, and by the type of chemical used for all the IRS districts or for districts that implement IRS. And then also we got the historic data of SMC rounds from 2015 to 2025 for the SMC implementing districts and regions. Then we also got data or historic data for malaria vaccine. The rollout from the 136 districts in Ghana. Then also the IPT and then the EPI coverage data for Ghana were all extracted from 2015 to 2025. Then for the transmission determinant, we looked out for the survey data on prevalence, that is mixed 2011, DHS 2014 up to the 2017 data. Then the chef's monthly rainfall rasters, land surface temperature, night light, and then the slope cover rate. Then we also took our entomological data from our published literature and then the National Malaria Data Repository. Then also the population dynamics. Now, data quality is very important, and for that matter, special attention was paid to data quality in this subnational tailoring, because the wrong data will send the wrong, right strategy to the wrong place. Once you have wrong data, you may send the right strategy or intervention to the wrong district. So data management was very key. So I would like to spell out what actually was done in terms of routine data quality. All right. So what we did was to extract the data and clean, and just like I mentioned, from 2015 to 2025 by facility, by month, and then by district. Then what we did was to check the completeness of the data. So we determined facilities that were active. Then we looked at the reporting windows, and then facilities that were closed versus facilities that were inactive. We also did consistency checks to determine the logics of the data. So for instance, all outpatient cases should be greater than or equal to suspected, and then suspected also greater than or equal to tested cases. In the same way, tested cases should be greater than or equal to confirmed. So all these pipelines were put in place. The point is to determine outliers in the data. So we use various scores to determine outliers, and then we also did imputation of data using some formulas, the rolling median for facilities that fail to report in less than 3 months. And then we also use the Kalman smoothing approach for facilities that fail to report between 3 to 6 months. And then for facilities that didn't report for 6 months or above, they were regarded as facilities that were closed down. Let's take note that confirmed zeros and structural not applicables in the data were maintained. They were never imputed, or data was not imputed for such confirmed zeros and not applicables in the data. Now, this slide shows the key data list that we used. So at the foundational level, we looked out for the regional and then the district admin boundaries, which we actually got the health facility GPS coordinates and the official population estimates for all the years 2015 to 2025. Then we also look at prevalence, infection prevalence, which by month for 2015 to 2025 and by district level. Then all-cause mortalities. We also got this from the DHIS2 by facility from 2015 to 2025 at the district level were extracted. Now, all data pulled at the facility level after cleaning were reaggregated to the district level for, the next level analysis. So to continue with the key data list, we had the confirmed malaria cases, which we disaggregated by under 5/5. And then we also had the number of anemic cases, malaria inpatient admissions, malaria deaths for under above 5, and anemia inpatient, anemia deaths, reporting rates for all the reporting patient and then outpatient. Then for routine interventions, we also took data from the EPI data, which we had the IPTP. We also pulled, all those data for IPT1 to IPT5, LLIN coverages through the EPI and ANC. We also got in. So in a nutshell, fine detailed level data was collected across the country and then cleaned and appropriately used for the subnational tailoring. Now, I mentioned the quality of data and then the completeness of data. So I want to dive into detail what was actually done across the country in this year's subnational tailoring. Very good. So right side of the slide shows the facility reporting activity time, which, according to the legend that we have here, we have the reporting status, which is we have active facilities, which are dark, then active reporting, active facility, but did not report are dark in color, then active reporting green, then closed facilities, and then inactive facilities. Okay, so what we did was to look at the date of first reporting of a particular facility. And if a facility had not reported for that date, we flag it as an inactive facility. Then if a facility reported any value, which is, not applicable, then that facility used that particular indicator and it is flagged as an inactive reporting facility. Then also if a facility reported any data or a false data within the window of non-reporting for about 6 months, that facility is flagged as closed. Then also, if a facility reported a value and the value is not applicable, we consider that as a likely omission for this indicator and flag the facility as active and but did not report. It means we have a missing data and that we needed to do imputation. Then lastly, for any facility that reported a value which is 0, we regard that 0 as a confirmed case or a confirmed 0, and then we keep that 0 as an active facility which actually reported 0. All right. So in terms of data consistency checks that we did, which I mentioned earlier on that all outpatients should be less than or equal to suspected cases, and then in that order, I mean, having a heat map of it shows the prevalence of the logical inconsistencies, I mean, within the indicators across the various regions. And so we can appropriately see which regions are prevalent, I mean, in terms of data inconsistencies within the various age groups of the indicators. So that is what this heat map seeks to show. Now, we also flagged out outliers across all variables. I mean, within each age group, we try to determine which outlier are in place, and then we apply our smoothing to the outliers that we get. So this is just showing for the various variables, and then in age groups, which outliers were determined in them. Now, before we did the imputations, we just came up with this time series data or time series plots of the various of some selected districts to look out for how the data looks like in terms of quality. And here we can see that there are some outliers in some at some point in time across the time series, whilst I mean others are also showing normal in the time series. So this also guided us as to how to do our imputation so our data is not distorted. All right. So for our imputations, these were the logics we use. We input for expected missing and then flagged outliers. So once there is missing data, and which I mentioned that for missingness, we are looking out for facilities that have not reported for a window of less than or equal to 3 months, which we use the rolling median. And then for facilities which report within 2 to 6 months, we use the Kalman's approach. Then for greater than 6 months, we regard that facility as being, closed down. So the outliers these were the imputation logics we did. Okay, so but for the imputation, we excluded all facilities that were closed down. Now, in the summary for the imputation, this, I mean, a snapshot of it. So this just to show that we only did imputation for active and then facilities that were expected to report by the reports. And for the Kalman's approach, we did an imputation using the less than 3 months of non-reporting. Then for outlier replacement too, we also did imputation as, the same, using the Kalman's and then the rolling median for the facilities. And so we didn't do imputation for true zeros and then for facilities that reported not applicable or that are not expected to report. And then also facilities that were closed. Now with this time series data that is showing, these are data for pre-imputation time series, then post-imputation time series. So we actually wanted to see how our imputations actually went. So the red dot with that line in it shows the imputed final data. When I'm looking at post-imputation time series, Ashanti are dancing up formula. That data is what I'm looking at. And the take home of this time series shows that the imputations actually didn't distort the data, and then it fell normally in line with the expected data for the country. And then expert knowledge from the country actually agreed that this is the data that is required for the subnational tailoring. So it continues in this slide as well. Okay. So for the intervention, so what I mentioned earlier on were the routine data. So for the intervention data, we looked at the case management data, we looked at the routine interventions, ITN, IPTP, and then the other SMC, mass campaign, the IRS, the vaccine data, the EPI coverage, just like I mentioned earlier on. So this historic data were linked with the health districts, and then map were generated accordingly according to the coverage of such of those interventions. So we also review the completeness, the consistency intervention data, and also verifying data available in all reports. So the good thing is that this work was done in addition with the program, and so any level of data that is we got were discussed appropriately and before use. So other transmission determinants we look out for the entomological information from the National Data Repository. Currently, Ghana National Malaria Data Repository, which houses our end data for now, and all the other data sets will be put into it in due course. We also use monthly rainfall obtained from the satellite imagery from CHEPS for 2015 to 2025 to look at our seasonal data. And all these data were also linked with the health districts and appropriately reviewed for completeness and quality and then the consistency. We also verified the need for additional calculations, reviewing and data available in all reports in these two data sets that we use. What we did was to use a phased approach or 3 levels of adjustment for the estimation of our incidents. So the first one was to have incidents, and we use the confirmed cases, which include the input. This is actually the baseline management data which were reported in the period. Then the level of adjustment we did was to adjust the incidence based on percent. This is we have it's presumed in the data. Then the last level adjustment was adjust the data based on care seeking behavior across seeking data from the DHS, MIS across 4 survey years from 2014 and up to 2022. So these were the various adjustments we made, and based on the expertise of the program and having various levels of meeting with program experts, we came up with which adjustments the program thinks is beneficial to the country. Now, we did a stratification, and with the stratification, we did it across all the 261 districts. And what did we determine? We determined the prevalence, where we did a geostatistical model at a kilometer grid or a kilometer square grid using 6 national surveys from 2011 to 2022. And we also considered environmental covariates such as rainfall, the slope, nighttime light, and all those to determine what to put where. Then also adjusted our incidents based on the HMIS confirmed cases, which we did for adjustment 1, testing rates, then adjustment 2, care seeking behavior, which I mentioned that we use different adjustment approaches to do this. Now we came up with various scores for the epidemiological strata for each district based on a composite score of the parasite prevalence and then the incidence for each district on a scale of 1 to 7 each. So strata 1, which is very low, had 2 to 4 scores, then low, medium, high, and then very high fell between the 12 to 13. So we had low being 5 to 6, medium to 9, high 10 to 11, then very high being 12 to 13. So if any incidents if we determine a certain district incidence of and prevalence falling within each of the age group, then a certain intervention is designed to fit that particular category of strata. Also, we determine intervention history and then the seasonality patterns for our data, and then onto data using micro and then urban area micro stratification and then population vulnerabilities, and before an intervention is fit into any of the stratum. Now, with data, from data to decision, what did we do in terms of the intervention tailoring? What we did was to make sure that for interventions such as mass campaigns, we expect to do mass campaigns in all 261 districts except the regions that will be enjoying IRS. And there were specific questions the program asked which needed answers. So the first S&T question for mass campaign was deprioritization and funding cuts. What should we do under if we have that scenario play? The logic or the priority logic or answer to it was to use or to deprioritize urban areas with low transmission first. And so these were the areas we think deprioritization would take place in the face of funding cuts for mass campaign. Now for IRS was expanded from 25 districts to 38 districts. And the question from the program was where to scale back if IRS is underfunded. And that's the team came up with was with low burden areas, which also enjoys alternative vector control interventions. So those were the areas that would be deprioritized in the face of underfunding of IRS. Then for SMC happens in 69 districts currently. And the question from the program was, if we want to scale back the SMC, do we do round deprioritization or geographic deprioritization? And here, the answer to that was we were looking up for districts with low level seasonality and then using the burden score to determine which districts we will scale back in terms of the rounds or the geography. Then for malaria vaccine, currently we want to have the coverage in all the 261 districts. And so is there a need to update this criteria for malaria vaccine? The answer to that was to have the new transmission data, then looking at the funding scape to determine whether to scale up malaria vaccine or not. Then for interventions such as mass drug administration, IPTSC and then PDMC, which are novel interventions, the new districts to enjoy this are 23, 132 and then 261 for the interventions mentioned. Then the question from the program was to define the eligibility areas. So we looked at for areas with high disease burden areas plus care seeking and then urban, or whether it's urban or rural area before we can put in that intervention. Now we had a framework of prioritization which was driven mainly by data. And we use two approaches, whether we have a scale up or expansion of interventions or a deprioritization, whether we scale back interventions. Now for the expansion or the scale up of interventions, we considered new interventions or completely review of existing ones. So we focus on how priority areas first. And then, for instance, IRS, we reviewed the 25 to 38 districts in expansion. And then for malaria vaccine, we have a full or national rollout eligibility. Then for IPTSC, MDA, we define the eligibility districts. Then for deprioritization and then the scale back, we also looked at, for SMC, we look at geographic or operational scale back of existing interventions. And then here we considered lowest priority areas for deprioritization first before the rest. Then for ITN campaigns, we look at urban areas with low transmission intensity. Then for IRS, we looked at low burden districts with good bed net coverage. So that is why we probably will deprioritize IRS. Then for SMC, we are looking at either we go for fewer rounds in districts with low seasonality. So that is, the deprioritization approach we adopted. Then for geographic deprioritization of SMC, we are looking at districts below the burden threshold that were set by the program. Now, the analysis team for Ghana's SNNT for this year had multi-stakeholders. So we had the Ghana National Malaria Program, which had the program leadership leading, and with the MNE focal and data management and surveillance monitoring and evaluation unit doing all the work for the Ghana National Malaria Elimination Program. Then we also had a team from the Ghana Health Service, PPME, also in charge of the Health Information Management System data collection. Then we also have Ahadi, who coordinated the whole analytical processes. And so they supported in terms of analysis and stratification, in terms of intervention targeting and modeling. We also had MAP, Malaria Atlas Project, with the geospatial modeling of the prevalence, care seeking, treatment seeking behaviors for the SNT this year. We also had team from WHO, the Technical Oversight and Program Review Committee, which were also on board. Then the Meteo Bureau of Ghana which also gave us the data for the rainfall, the climate, and then the population data, which was gotten from the National Statistical Bureau. What are the key insights and lessons we have learned so far from the work we are doing? I mentioned that it's a work in progress. So the key insights, the first one is data quality is non-negotiable. We cannot negotiate, data quality when you are doing SNT, because the popular saying that garbage in, garbage out, plays a role here. If you put in the wrong data, you are going to send the right intervention to the wrong place. So rigorous cleaning and then the imputation, was very helpful and then very useful for us as a country. Checking the completeness, the consistency, the outlier, and then all the imputation we did was very helpful. Then secondly, we realized that care-seeking adjustment changed the game. The HMIS data, underestimated the true burden of malaria. But adjusting to care-seeking actually improved the data by about 2 to 3%. So they were transparent on everything that we do in terms of care-seeking, and then all stakeholders agreed to the sensitivity of this data. Then thirdly, multiple models were applied for sensitivity. Like I mentioned, different partners did different works, and so we were able to do very good work here. Then the last one, which is SNT requires investment in data infrastructure. So if your data looks bad as a country, it means definitely you are not going to be able to plan effectively, and any modeling work you do with the wrong data, I'm not sure you have good results. So these are the key insights and lessons we learned. So in summary, we acknowledge all the partners. I cannot mention names one after the other, but let me mention Ahadi, all the team members in Ahadi, Prof. No, Prof. Jalen, and Bea helping out in all the analysis. MAP, Samuel Pong, my boss, then my NMEP team, the program management team, Dr. Hilarious Abiu, and my head of department, Mr. Wajid Ahmed, and everybody here on call. We acknowledge all of you and all the health team members in Ghana. Thank you. So, ready for questions and questions. Can I be heard?
Thank you so much, Ferguson. That was really fabulous. And I know it's a very busy time right now, working on the wonderful presentation. I don't know if you can see the chat, but you have had so many compliments in the chat. Really, you're famous. I expect you to receive lots of fan mail at this point. Congratulations.
Thank you.
And can I pass to whoever is moderating to handle the Q&A?
Antonio, are you still with
was muted. So sorry. So I want to this nice presentation, providing a really important information on how we can use subnational tailoring for addressing a number of challenges that we are having in the fight against malaria. I think this is something which is very important, and we really want to really continue on that. I don't know. There should be questions. I didn't look at the question side to see
I think we have
if there were questions.
we have some in the Q&A here.
Yeah. How to achieve consensus among all the stakeholders for determining how to target each intervention? This is one question from the Q&A. Please, Ferguson.
All right. So, Hannah, thank you for the question. All right. So, basically, this work is not done in isolation from any of the partners. We all come together, sit down, look at the baseline data, or look at the source data, analyze it, and then in a meeting, we have, weekly meetings, sometimes 2 weeks we meet to discuss what has been done so far. So, of the intervention targeting, we all started the whole work afresh. So once we come together, this is what the data says. With experts from the program, what do we actually accept? Then we accept and then move on. So that is basically what we did. Thank you.
Thank you, Ferguson. So if there are any questions in the Q&A, no question. For the work which is presented. I don't know if someone has a hand up to ask a question. Or everything was really understandable by everyone. If everyone understood everything, no question. Yeah, the presentation was really nice and really put in a manner that was quite easy to understand. And I think I'll congratulate you on this great work. It's very nice. Yeah. Yeah, Shannon, you wanted to say something?
I see a couple questions. Do you want me to jump in and read those questions?
Yes, please. Please go.
I see one from Peter. Fund cut affects the current fight against malaria. What mathematical model was used and what optimization technique was used?
All right. So can I go ahead?
Yes, please.
All right. So thank you very much, Peter. I think so I'm earlier on mentioned that this is a work in progress. So the aspects is not complete yet, but part of your about prioritization. So I think as a country we will not want to some interventions, but in the face of funding cut, it means you have to scale back interventions, which would not really help the country. So that is what I have to say. But the rest of the mathematical model and then the rest of the optimization, they are work in progress. Maybe in the next opportunity, we will present all those findings and outputs for everyone to see. Thank you and over.
Okay, I see another one here too. So using the mathematical modeling, is it possible to get efficacy of intervention to be 100%? And if yes, how do you explain this realistically?
Okay. All right. So thank you for that question. So yeah, just like I mentioned, once we have mathematical modeling complete, then we can answer every question related to the mathematical modeling aspect of the work. So maybe in the next opportunity when we have the floor, we'll be able to deal with all the areas in terms of the mathematical modeling that we have done and how it's working well in our perspective. Thank you.
And let's see. And then I have another one here from Fiona. Are the districts able to continue with the tailoring process independently without donor support?
Oh, okay. So, Fiona, if I understand your question well, you want to know whether the districts are able to continue with the tailoring process independently. Okay. So, I think what I'll say is that in our previous stratification we did, I think we had districts coming together and they've been trained on how to do the stratification themselves. And so I think it's feasible they can independently do the stratification. Yes. But however, I mean, what we are doing currently is on a national scale, so it's being done at the national level. Thank you.
And then I have another here. How long has the NMDR been in place in Ghana? What are the concrete benefits of its implementation?
Okay. So NMDR has been in existence for about 5 years now. Currently, we are doing a phased approach in terms of the data that is in the system. And now we have all our entomological database, malaria data repository. So the next phase we are looking at is for pushing the routine health data for malaria, the demographic data in relation to whether the population and all the other variables to the National Malaria Data Repository. So National Malaria Data Repository is very important for any country. Thanks. So because once you have your National Malaria Data Repository, anything you need at all, you can just, do in terms of data analysis, the intervention history should all be there. And so you don't need to roam about it. For this year, we have to actually go into private organizations which do entomology, data from them because they are part of the country, go into research data. But ideally, if we had the National Malaria Data Repository, all these should have been there already ready for analysis. So that is just one great importance of the National Malaria Data Repository.
Great.
Thank you.
All right, we have a couple more here. Let's see. Gabriel says, thank you, Ferguson, for excellent work and presentation. Which entomological data did you use, and what were those actually quantifying at the community level? Could you elaborate a bit on your epidemiological scoring approach?
Okay. So for the ento data we used, we actually use a insecticide resistance data from our entomological sites. We have entomological sites across the country, sentinel sites across the country. So we got the resistance data for all the sites. Over time, we also got which type of mosquito leaves were, or which is prevalent where at each point in time, and what insecticide or actual insecticide they are resistant to. Over time, all the reporting sites. So those are the key areas we key data got from the N2 sites. Then also to elaborate on the scores, I'll just try to reiterate that we did a score level for prevalence and then incidence. Now, if a particular district falls in each of those strata, the combined score, we call them strata, which we define as very low, low, medium, high, and then very high. So if any district score fall within any of these categories, you are appropriately, put into that category, and then intervention is designed to fit that category. So that is how we just determined the scores. We use the prevalence and then the incidence scores, and then we actually determine which intervention fits you. Yeah.
Great. Thank you for that thorough answer. All right, let's see. The next question. I'm not sure if this has been addressed yet. How do you explain the uncertainty in the models to stakeholders?
So thank you for that question. So it is very important at each step of the whole SNT, from preparation to monitoring and evaluation, which you also do the modeling aspect. It's very important to be open to all stakeholders at each point in time. Any key decision you take, key stakeholders will have to know and also agree to it, or have to have the explanation to it. And so they all have to acknowledge the downs of that or whatever modeling you are doing. So you just have to be open as much as possible to them.
Beautiful, thank you. So we're at the hour. I think that we can take a look at the questions offline perhaps, and see if we can address some of those at a later date. But I think we're going to need to close the session. Sorry, we weren't able to get to all the questions. It looks like you have many questions and discussions here. Go ahead. I'm going to turn it over to you.
Okay, so we want to thank Son for really providing a very interesting presentation. So all those who have presentation, who want to present, they are welcome to also come to us and tell us what they want to present. So for today, I think we'll just close. There's no more announcement. I don't know, Shannon, Selene, have any announcement?
No, I think we are
Okay.
Okay, so if you are okay, so thank you again. Thank you, everyone. Webinar, I think will be short.